out of order here. Because anti-infectives, which is going to be like your antibiotics and antimicrobials, is kind of a big chapter. We're going to be doing that next week, okay? Doesn't mean it's horribly difficult. It's actually it makes a lot of sense. But it's a little bit longer and a little bit more involved. Okay. So when we talk about infection of any kind, it can be infection by bacteria, it can be infection by fungi, it can be infected by viruses, okay? A whole host of things that can cause infection within the body. Generally speaking, the fungal and viral components of our, if you would call it our ecology in our body, okay? And a lot of that has to do with our mouth as being the entrance into our body. We have all these components always there. So you always have all of these different bacteria and protozoa and viruses and fungi. They're there, okay? They're always present, but they're in balance with each other. And if something throws them off balance, okay, that's when we get an infection. Or if our immune response is down, okay? You notice you get sick when you're tired and you're stressed and your immune system's down. So you're talking about the host response, the ability for us to fight any type of infection is important, as well as the strength of whatever it is that's infecting you, okay? So all of those things are going to make a difference. And if we don't have our normal responses, we fight this stuff all the time. We don't have those in there, or something happens to throw them out of balance. So because we skipped over the antibiotics, if you will, the anti-infectives, have you ever heard of someone getting an overgrowth of other things because they were on an antibiotic?
Yeah.
Yes, like a yeast infection, right? Okay, so those are the types of things we're going to be talking about. So antibiotics and anti-infectives, which of course is chapter 7, are effective against microorganisms, okay, that are bacterial. Bacteria, protozoa, rickettsia, trichomonads, amoebas, and spirochetes, okay? All of that gross stuff. They're effective against that, okay? But they are not effective against fungal or viral infections. This is why your doctor doesn't usually write you a prescription for an antibiotic when you have a viral cold, right? Or maybe you've had the cold for so long, now you're starting to get a super infection of something that's bacterial. Okay, like typical of people that get the cold and then they get the sinus infection. And then they might write you a script, right? Because you might need it at that point. But generally speaking, these do not have any effect on those at all. We usually start to see the fungal and the viral overgrowth when something is out of balance, okay? And the normal part of our flora gets out of hand, okay? But it's not normally just introduced into there, okay? So the viruses are really, and fungi are really different animals, if you will, than the bacteria we're used to. And antifungal and antiviral agents really do have a place within dentistry, as well as the patients we're going to encounter are going to be people that have these issues that will show up in the mouth that are associated with these types of infections. So the antifungal agents that we're going to be talking about are mostly those that are going to be controlling a Candida albicans infection, Candida, yeast infection, that kind of thing. The antiviral agents, the infections that we're going to talk about are going to have to do with herpes infections, HIV, human immunodeficiency virus, hepatitis, and those are the ones that we will concentrate on because those are the ones for which there is some robust therapy, if you will, or things that we can do about that. So we're going to start with the antifungal agents. And again, the fungal infections will be encountered in the dental practice. They're not really, really common, but you will definitely see them, and they are more difficult to treat. They're insidious, okay? They're sneaky. The people that are most likely to contract them are those that are what we call immunocompromised. Their immunologic system is compromised by other problems that they may have. You see this in cancer patients, people with HIV, people who are on corticosteroid treatment for a long period of time because their body's defenses are just knocked down. And these types of fungal infections can become chronic because these people that have these immunocompromised positions are not often taken out of that position until they're well. And for some of them, these are chronic diseases, so it's something that's not going to go away, if you will. The fungal infections are divided into two types, those which are systemic, and these are called systemic mycoses, and these are serious infections that require medical intervention. Then there are the localized ones, okay, or the superficial infections, which we treat in a local or a topical way. And the most common of these are Candida albicans. So they call this a mucocutaneous infection, and it's generally on the mucous membranes, if you will, oral or vaginal. And tinea, which is on the skin itself. And some examples of that are something like athlete's foot, ringworm, jock itch, that kind of thing. And there are a lot of over-the-counter medications that are available to treat these, because they can be over the counter. Number one, you want to be able to get to them quickly, and also because they're not actually absorbed systemically very much and put in a topical way, they're fairly safe. One of the most commonly used drugs for Candida infection, including in the dental practice, is going to be nystatin, okay? Oral candidiasis, nystatin, oral candidiasis. Just absolutely positively know this drug. And this is a petri dish where you see a yeast infection. It's not really yeast like, you know, what you raise bread with, okay? But it looks a lot like yeast molecules, so they wind up calling it a yeast infection. It is the most common oral fungal infection, Candida albicans. And again, it's part of the normal flora, but it doesn't often overgrow, but occasionally it does, and we have to deal with it. It happens in those immunocompromised patients that we talked about. Chronically ill people, elderly people, people with AIDS, uncontrolled diabetes. Take uncontrolled diabetes, an elderly person, and put a denture on them, and that often winds up with oral candidiasis. You have to remove that denture, and you may have a candidal infection going on there. So the nystatin is both fungicidal and fungistatic. What do you think the difference between cidal and static would be?
Cidal is to kill.
Right? And static would be?
Treat.
Yeah. To stop and arrest. Yeah, treat it by stopping and arresting it. So generally speaking, one is one way or the other, but this can actually be both, okay? And a fungicidal one means that it's going to kill off what's there, and a fungistatic means that when you remove it, it starts to grow back, but it's both. So it actually arrests it where it is, and then it kills it. So the long and short of it is it's very, very effective. When we talk about our antibiotics, when we talk about our anti-infectives next week, generally speaking, definitely speaking, they're in one category or another. So they're bactericidal or bacteriostatic. Its mechanism of action is to bind to sterols, and there are a number of different sterols that are located in the cell membrane. And there are a bunch of different kinds, but if you remember the word stero, that's fine enough. And what it does is it binds to them and it breaks them apart, so it makes the membrane leaky, and it kills the cell by doing that. Okay? It kills the fungus cell by leaking out its contents. Bacteria don't contain sterols, so therefore, if you had a bacterial infection and you gave someone nystatin, it would not do anything for it, because those cells are not subject to being killed off because there's no sterols actually in their cell membrane. So it's not effective against bacteria, just like the antibiotics are not effective against the fungal cells as well. It is not absorbed through intact skin or mucous membranes, okay? So it's going to work on the fungal virus, but it's not going to get in there. Poorly distributed through the GI tract. So you're going to see in a minute here, we're going to actually swallow it because it's not going to be absorbed and go into the system. It's not detected in blood. And if you swallow it, which we do with some of our ways of dosing this, it is excreted unchanged in the feces. So it doesn't do anything to the body except in the topical area where the infection might be. So it's fairly safe to use. You would instruct a patient to use it for 10 to 14 days or 48 hours after the symptoms disappear. This is a really important thing to tell patients. So it's not as soon as you see the symptoms disappearing. Give it 2 more days, keep using it, kill that thing off, okay? Because if you don't, it will come back with a vengeance, okay? It will come back with a vengeance. So make sure that you instruct a patient to use it. I would just, honestly, with a patient, I would just say just use it for 10 days. Don't even tell them the rest, okay? Because if you say stop using it, you know, in 48 hours after whatever, they're going to stop using it as soon as it feels better. So just tell them to use it for that period of time. It's not cheating, you're really giving them proper information. It's available in several different forms. One is an aqueous suspension, and we know that a suspension stays around a shorter period of time or a longer period of time. Longer, right? It's viscous, it hangs out, okay? They actually, in some of the oral rinses, they actually have borrowed a term from the cosmetic industry. It's called substantivity. How long does it stay around? Okay, and they do tests to see how long lipstick stays on, and they took that word from the cosmetics industry. So something that's in an aqueous suspension is going to have a longer duration of action, longer substantivity. So 4 times a day is its dosing. Now here's one of the negatives. It contains 50% sucrose because it needs to taste good for most people to endure having it in their mouth for 5 minutes. How long do patients keep that Listerine in their mouth when you say at least 30 seconds? Like 3 seconds, right? It's like, and they're out. Oh, it's for, whatever, they can't even take it. So 5 minutes, that's really a long time. So they give it a pleasant taste because of that. And then it should be spit out or swallowed. There are pastilles, which is like a little lozenge, if you will. And those are licorice flavored. They do also contain sugar. They take about 15 minutes to dissolve, so why would that be a positive?
Quick onset?
Yeah, it's contacted with the infection for that period of time. It's killing it longer, okay? What would be a negative? People don't want to keep it in their mouth. And the sugar could be a problem, okay? And in general, we don't worry about the sugar unless we have somebody with diabetes, okay? And they have to account for the sugar content. But the 15 minutes is a great thing. Now, you can use the vaginal tablets. I know it sounds gross, but it's just a tablet. You can use the vaginal tablets because there's no sugar in them, but they're really hard to take, okay? So that might be something that might be recommended for someone who has a sugar problem, that kind of thing. And then there is a cream that's used, which could be applied either directly to the tissue or actually inside the denture itself in order to keep the medication in contact with the fungal infection for a longer period of time. And fungal infections on dentures really do happen quite frequently. You get elderly people that their mouth is somewhat moist, but they don't have a lot of saliva in there. They have a lot of xerostomia. They may have poor self-care. They may be in the care of someone else who's not caring for their denture very well, and they do wind up with this. People who have diabetes and dentures, this is something that happens more frequently than in the regular population. So something that you're definitely going to encounter this in your professional life, and probably as early as next year when you go out to some of the senior centers and you help them with their denture care. So something you will want to look out for. The adverse reactions for this, because there's no absorption, right, are going to be fairly minor, okay? So little absorption occurs if it's taken topically or orally, but with higher doses, just like with anything else, you can cause nausea, vomiting, okay, that can occur. And the sugar in the suspension and the pastilles needs to be considered if someone has xerostomia and carries risk, okay? So you might instruct them what, not to use it? Maybe to have really good oral hygiene, to brush and floss first. Okay, I would say brush and floss afterwards, but we want it to stay in the mouth, right? So get rid of the bacteria, and the sugar's not going to have as much of an effect, right? You got to have both. We talk about people having a high sugar diet. Yes, that's not good for a lot of reasons, including, nutritionally. But if you don't have the bacteria in your mouth, it's not going to have an effect. So one or the other or both, okay, would be even better. And if somebody has diabetes, they need to account for that intake of sugar. So they can actually look at the content of the sugar by looking at the grams of sugar and knowing how that would affect their, if it's insulin intake or whatever medication that they're taking. It's very, 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 I said that too many times, important to note that this is not shown by studies to be effective for oral pharyngeal candidiasis. So one that goes into the pharynx, deeper into the throat, okay? So nystatin would generally not be used for oral pharyngeal candidiasis. Some of the other drugs that are used in dentistry have the azoles as a suffix, okay? So this would be a good way, starting now with all of our drug groups, it's really good to look at some of these suffixes because when new drugs come out and they have the same prefix or suffix, you'll be able to identify what disease condition they're for. It's really, really helpful because a lot of new things are always coming out. So those include clotrimazole, ketoconazole, miconazole, fluconazole, and itraconazole. I actually want you to be familiar with all of these. They're all quite similar in how they work, their mechanism of action, and if there's something specific to one of them that's important, I will emphasize that for you, and it's something you should know about because it's important in treating your patients. But you should be familiar with all of the drugs that we're discussing today. There really aren't that many. Okay, so the clotrimazole, okay, this is important. It's effective for local treatment of oropharyngeal candidiasis, and we can see this is going not just in the person's oral cavity, but basically down their throat as well. So this is something that you would see. You would know that this was abnormal? Yeah, okay? And I guarantee you, you're going to encounter this, okay? You're going to encounter this. So you would definitely know something was wrong here, and that may be indeed the reason somebody comes in. This actually can happen fairly asymptomatically. People might just have kind of a weird taste in their mouth or notice that their tongue is coated. Under the denture, people don't even know it's there sometimes until maybe tissue gets, inflamed and begins to slough, okay? But this one is, so if I asked you a question, what would be appropriate for oral pharyngeal candidiasis, you wouldn't tell me nystatin, right?
No.
You would tell me clotrimazole might be one of those drugs, okay? It is used as a lozenge 5 times a day for 10 to 14 days, again, or 48 hours after symptoms disappear. It is a slowly dissolving sugar-containing lozenge, okay? There are actually several different forms. And it would be done 5 times a day for 10 to 14 days. So do you see how 5 times a day for 10 to 14 days, the sugar might become an issue? So as an oral care provider, this would be where you say to the patient, I want your oral hygiene to be as perfect as possible during this time. This will help you to get rid of this infection, okay? And we won't have to worry about the sugar, that kind of thing. Maybe bring them in for another fluoride treatment. Do a fluoride binder before they leave. Whatever we can do, I mean, we're in a position really to help. If a doctor prescribes this and doesn't give them those kinds of instructions, which they tend not to do as much as we do, okay, you should be giving them the instruction. Maybe they'll come to you already having this problem and already having something prescribed for them. There is a cream, yeah, for tooth.
But that's the case for the caries prevention, right?
Yep.
Caries risk. Diabetes, right? Diabetes would be another one.
Diabetes is a risk for a couple of reasons. The sugar content, and also just having diabetes because of the xerostomia and the immunocompromised position they might be in, depending on how well controlled they are. Well controlled diabetics are usually in kind of similar position that we are, okay?